Prostatitis and Vaginitis by David Garrison, Sarah Hassan, Rebecca Hornung, and Carol Carucci. Prostatitis is inflammation in the prostate that can block the flow of urine from the bladder. It can result in urinary retention, which increases the risk of infection in the bladder. Prostatitis can be classified into 4 subtypes, which include acute bacterial prostatitis, chronic bacterial prostatitis, inflammatory or non-inflammatory chronic pelvic pain syndrome, and asymptomatic prostatitis. Symptoms include fever, chills, frequent urination, burning sensation, pain between the scrotum and rectum, fatigue, blood or pus in the urine, lower back pain, and erectile dysfunction. Prostatitis is most common in men between the ages of 20 to 50. Non-infective forms of prostatitis may be associated with autoimmune disorders, but the pathophysiology of chronic bacterial prostatitis is not well understood. It is possible that it may involve development of bacterial biofilms. The proposed mechanisms of acute bacterial prostatitis are infiltration of pathogenic organisms ascending from urethritis, cystitis, or epididymal bronchitis. It can also be from a biopsy of the prostate or manipulation such as having a catheter. A less common cause of acute prostatitis is hematogenous/lymphatic seeding from sepsis or infectious sources in the body. This is a diagnostic algorithm for suspected prostatitis. Rational drug selection. Treatment of prostatitis is guided by culture or biopsy results. Acute prostatitis is typically treated with fluoroquinolones because they have the best pharmacological properties. Selection is based on the ability of the antibiotic to penetrate the tissue. The prostate is alkaline and the tissue is difficult to penetrate. Those antibiotics that are non-protein bound, have a small molecular size, a high lipid solubility, a low degree of ionization, and a high serum concentration can penetrate the tissue enough to get rid of the infection. Other antibiotics that can be beneficial in treating prostatitis are Bactrim, clindamycin, doxycycline, and azithromycin. Once therapy is initiated, it is important to monitor current continuing symptoms, response to therapy, and adverse drug reactions. Then the provider needs to do a follow-up culture to ensure therapy is completed. Fluoroquinolones interact with antacids, anti-diabetic drugs, glucocorticoids, and warfarin. Antacids interfere with GI absorption, leading to decreased serum levels. The combo with diabetic medication can either increase or decrease serum blood sugar. Combination with glucocorticoids increases the risk of tendon rupture, and the effects of warfarin may be increased, leading to the possibility of excess bleeding. Ciprofloxacin interacts with caffeine, leading to decreased amounts of caffeine being excreted, and phenytoin levels can be increased or decreased when taken with Cipro. Side effects management. There is a black box warning on the development of tendinitis and tendon rupture. The risk is greatest for those patients over the age of 60, those on steroid therapy, those individuals with a previous tendon disorder, and with strenuous exercise. Other side effects of prostatitis are increased intracranial pressure, dizziness, confusion, tremors, hallucinations, depression, and suicidal thoughts. Avoid fluoroquinolones in patients with a seizure disorder, as it can lower the seizure threshold. The medication may cause abdominal pain, nausea, altered taste, and photosensitivity. Patient teaching. Patient compliance with taking the antibiotics as prescribed is vital for success. The patient needs to stay adequately hydrated. They may use NSAIDs or antipyretics for pain and fever. It is imperative that they follow up with a provider to ensure therapy was a success. Bacterial vaginitis is inflammation of the vaginal mucosa caused by gastrointestinal tract flora, chemicals in bubble baths or soaps, and from foreign bodies, such as toilet paper. Symptoms include vaginal discharge, vaginal irritation, pruritus or itching, or erythema or redness. Diagnosis is achieved by taking a sample of vaginal secretions and sending a vaginal culture to the lab for testing. Bacterial vaginosis is vaginal inflammation caused by floral disparity where lactobacilli, or good bacteria, decrease, therefore allowing other pathogens to grow and cause infections. Bacterial vaginitis is the most common vaginal infection that a woman gets. Symptoms include a gray, thin, fishy-smelling vaginal discharge. Diagnosis is again confirmed by testing those vaginal secretions, and treatment is achieved either through oral or topical antibiotics. The most common and effective treatment of bacterial vaginosis is oral metronidazole, or Flagyl, and is prescribed as 500 milligrams twice a day for 7 days. Metronidazole is well absorbed, available in different forms, available in generic form, is affordable, reaches peak serum levels within 1 to 2 hours, and the half-life elimination is 8 hours. Monitoring includes evaluating results of a culture and sensitivity prior to starting metronidazole or treatment, serial CBC results at baseline, during therapy, and with prolonged use or repeated course therapy, close monitoring for the elderly and those with liver and kidney disease, assessment for peripheral neuropathy and seizure activities. If noted, then discontinue use of the medication. Test for C. diff if diarrhea develops after therapy is initiated. Do not drink alcohol while taking metronidazole for the entire course of the medication and for 24 hours after medication is completed. Individuals taking disulfiram need to stop this medication 2 weeks prior to taking metronidazole. References. Continued references.